All right, welcome back to Dr. Molly's Most Excellent Med-Surg 2 online lectures that I'm sure you're all starting to just hate by now. All right, this week we're going to do skin and burns. So we're going to start out you're going to be tested on chapters 61 and 62, but chapter 60 might be a really good review for you guys if you don't remember stuff about the skin from anatomy, physiology, or pathophys. So let me just point out some stuff that you might want to go over in chapter 60. Page 1753 just has your basic anatomic structures of the skin. That one's kind of important to know because it matters when you start talking about different degrees of burn. So you have to know the difference between your epidermis, your dermis, your subcutaneous layers, where the nerve endings are, where the hair follicles begin, stuff like that. It's just kind of a good thing to sort of go over if you're not familiar with that. The rest of the stuff in here, you should be familiar with. A person's fingernails can tell a lot about if they have certain conditions, like some of the cardiac conditions will have, can cause clubbed fingernails. You can, cyanosis and stuff shows up a lot in the skin. Jaundice will show up a lot in the skin. So you can tell a lot about what things might be going on underneath the skin just by doing a good assessment of the skin. The skin is your largest organ by a long shot, covers the entire body, and is really instrumental in preventing infection and maintaining heat. So those are two major components of the skin. That's your first line barrier, and it regulates the control of heat. So I'm sure you guys all know that. The other things I want to point out, again, the geriatric considerations on page 1755. We've talked a little bit about this before, that the skin is an obvious sign of aging. The skin will thin. People who have been on long-term steroids tend to lose a lot of thickness in their skin. Their skin gets real paper thin if they've been on long-term steroids. People that age to get thin skin, they get wrinkly skin, their skin tense. I mean, it stays up instead of it's not as springy. Wrinkles are common. So just keep that in mind because you can't assess geriatric skin the same thing that you would.
Tipo, I'm going to hockey.
Okay, shut the door.
Okay.
You can't assess geriatric skin and the same way that you would a younger person and consider it to be the same, especially related to fluid and electrolytes that we talked about in fluid electrolyte section. There's a good chart on page 1757 about how to do a good skin assessment when you're doing your head to toe. Look at the figure 63 on the bottom of 1758. That's a good example of cyanotic skin versus jaundiced skin. Jaundiced skin, we'll talk more about this when we do the hepatic week. Jaundice, and that's just high levels of bilirubin, usually because of liver problems, will first show up in the sclera of the eyes. The eyes tend to get yellow. And then thin skin, like under the eyes, will start getting yellow. That's the first place jaundice shows up, but after jaundice gets advanced, then you'll see it in other parts of the skin. The other things you should know, erythema, that's a really common nursing word, red skin. You should be familiar with that. If you're not already, review that. The table 61 on, that's 60-1, on page 1759, that's a really good review of some dermatological words that we use in medicine, so you need to be familiar with some of those words. What's it mean if you say somebody has their skin is pallor, their skin is erythematous, they have hyperemia, polycythemia. What do those kind of things mean? So you might need to just sort of look through some of that stuff. I also like the table on pages 1760 and 1761 about the different types of lesions and issues that can happen with the skin. I gotta be honest with you, skin issues are vague and sometimes complicated. People will show up with rashes and hives, and they're very difficult to diagnose. Sometimes you have no idea why somebody's breaking out. You have no idea why they have a rash. They can't remember using a different soap, using different laundry detergents. But you as a nurse, those are some questions you might want to ask. If somebody is coming in and they're presenting with new lesions, new rashes, something different on their skin, you need to, the first steps in your assessment are find out are they doing something different or something new? Are they having did they introduce a new food into their diet? Did they take a certain food or vitamin out of their diet? Are they using new soaps, new detergents in their laundry? Those kind of things you need to assess because it could be the cause of it. Other times you're not going to be able to figure it out. It is oftentimes an allergic reaction. We'll talk about that a little bit when we talk about like allergic dermatitis and things like that. So it could be like, remember when we talked about in the allergy week, how people have a sensitivity to a certain allergen. It could be something like that, and you might have to find out, is it something that they're touching? Is it a contact dermatitis? So you need to ask those questions when you're doing your assessment, when your patients are coming in with new rashes and lesions. So look through some of those different words there. On page 1764, I told you about the different kinds of nails, and when you're assessing somebody's fingernails, what those different kinds mean. Now in somebody like me who doesn't, all my nails have gel on them, it's a little harder to figure it out, but if you're going to be an astute nurse, you'll be able to figure that out. So, that's about it for chapter 60. That's going to be just your review chapter. Okay, so now I want to go into chapter 61. This is the stuff that you're going to be tested on this week. Managing derm problems. There's quite a few derm problems. And they run the gamut of stuff, anywhere from the malignancies to severe chronic issues, some of them being autoimmune. Certain ones are different phases of the life cycle. So we'll talk a little bit about that. I'll tell you which ones I need you to focus on because you're going to see them more often, they're more common, and which ones are a little bit more rare. Okay, step 1, protect your skin. At all costs, you should be teaching your patients to protect their skin. So this means from UV lights, so outside in the summertime, skin protection, like lotion, suntan lotions with good sunscreens in them that block both UVA and UVB lights is essential, because that will prevent, millions of studies have shown that prevents the risk of developing skin cancer, because it's the UV lights that are causing skin cancer. People should wear good sunglasses also with UV protection so that they're not getting the UV lights and the UV rays into their eyes. They should not be basking in the sun. If they have cuts and lesions on their skin, those should be covered. This becomes a big problem in the construction workers who are working outside a lot. These big burly guys that use their hands, they've got really big hands that get really rough and crusty and they crack open. Another problem, and watch for this in especially your male patients or even your females who have their hair up a lot and they're working outside, the tips of the ears and the nose, very common spot for skin problems like sunburn, which can ultimately lead to some of the skin lesions, skin malignancies. So they have to be taught to cover their ears and their nose. And when you're assessing patients, especially if they've told you that they were a construction worker, they were working outside, they've lived in Arizona, they are in Florida where the sun is really intense and hot all the time, make sure you're assessing for those hidden spots that can have pretty significant derm issues. That's a big nursing thing, is to just prevention of skin issues, because a break in skin can cause infection, and exposure to sun can cause burns and tumors. The other thing that you should know about are the different types of dressings. Now, I just want you to skim through this to know that there are different types of dressings. And usually the rule of thumb in the world of dermatology is if it's wet, you put a dry dressing on it. If it's dry, you put a wet dressing on it. That's not 100%, but that tends to be if you've got a wet oozing rash, it just makes sense that you're going to want a dressing on there that is going to be an absorbent kind of a dressing. You're not going to put a dressing on a wet wound that is not going to absorb any of that. But if you have a dry wound, or something that might need some, like a hydrogel, then you would put something with gel in it. Some of your burns that we'll talk about the next chapter, you might have to put the silver, like Silvadene cream or silver infused dressings on there to help promote healing. So just be familiar with the different kinds of dressings. Some dressings are put on to actually cause debridement. So the dressing is like porous, and you'll put it down into a wound or an open wound, and then the debris and the dead tissue kind of gets in there, dries a little bit, and then when you take the dressing off, it pulls some of that debris, the dead tissue off with it, and then it's a form of debridement to help that wound heal, because the way that those wounds are going to heal is with good vascularization, good blood flow, and good airflow in there. You need to get rid of the dead tissue. We'll talk about that in a minute. So kind of skim through the different kinds of dressings. You don't need to spend tons of time knowing the exact words, because it'll change by the time you take your NCLEX, because they're developing new dressings all the time. The next couple pages with the lotions, the powders, the creams, the gels, these are all topical things. They're great for a variety of dermatological issues. A lot of steroids. They'll put like there's different kinds of steroids they can put. Steroids are pretty good to reduce pruritus, rashes, itching, that kind of stuff. Steroid creams are used quite a bit. Long-term steroid use does have some side effects, though. It can lead to, like I said earlier, thinning skin and stuff like that. Okay, now I'm on page 1772. Pruritus is just itching. A lot of people get itching for a variety of reasons. A lot of people in the wintertime, your skin gets dry, it itches. The biggest thing, the biggest problem with itching is when people tend to scratch. They'll start like scratching an itch or scratching, hives or something like that. When you scratch, it makes the pruritus feel better. However, you have bacteria and dirt in your nails, and if there gets to be a cut in that wound, then you can get bacteria down in the wound, and that's the bigger problem. So if you can reduce the itching, or teach somebody to not itch, or if they have to, like you could put like little kids and stuff that can't not itch, you can put mittens on their hands so when they're itching it doesn't cause such damage. But pruritus is really uncomfortable. All right, let's skip over to, I want to go to page 1774, the disorders that have secretions to them, the secretory disorders. And those are the ones that are going to be the wet, the oozing things on the skin. The biggest one that you'll probably see, and you probably have experienced it, is acne. Acne is, it can range from really mild that just gets cleared up with washing your face to really severe where some of these patients need surgery, phototherapy, chemical abrasions, things like that to clear it up. About 80% of the population has it. It's very common. One of the bigger issues is it's really common in adolescents, and adolescents are already going through a plethora of other emotional, personal issues. So when they start developing acne on their face, it causes all kinds of self-image problems, which they tend to have self-image problems anyways. So emotional component to acne is significant. And there are a plethora of treatments now, and I'm sure you're aware of them. Anything from like Proactive to X-Out, all the commercials that you're seeing on TV. Some of them work better than others. There's a bunch of topical stuff. Some things you can get over the counter, some things require a prescription. So if you have a teenager that you're taking care of and they've tried all the usual things, like washing their face, keeping it clean, avoiding greasy foods, although research has shown that diet doesn't have a lot to do with acne, you know, some studies are starting to indicate that some food groups may be more beneficial in skincare, like avoiding milk products, avoiding greasy foods. Things may tend to have some assistance in helping people that have severe acne. Yeah. Oh, so yeah, that's what I was going to say. If it gets really severe and the patient is not improving with normal stuff, I absolutely 100% recommend them to go see a dermatologist. Now, there is a medication out now called Accutane. Accutane has been shown to be very effective in treating adolescents that have severe acne. The problem with Accutane is that it also has been associated and linked with higher rates of suicide, which, as you know from your mental health, the adolescent years are that put a patient at higher risk for suicidal tendencies. So you do need to move cautiously with Accutane and make sure that the patient is not also developing suicidal thoughts, depression, things like that, and they might have to switch to other forms of acne treatment. So be careful with that if you have a patient coming to you asking you about Accutane. Make sure they don't also have a mental disorder, which is why that drug has to be prescribed by a physician. Okay, now I want to talk about the infectious dermatological issues. So the first one was the secretion ones, which is your biggest one is acne there. And then sometimes you'll have a dermatological condition caused by an infection. Impetigo is the biggest one. You've probably heard about impetigo. Impetigo is just a little bacteria that gets under the skin. It does clear up. It can clear up. It's often seen in children who are malnourished or in conditions that are not clean, not conducive to cleanliness. It's itchy, and oftentimes antibiotics are used to treat that, and then it'll clear up. You can just have some other like folliculitis and folliculitis, and now I'm on page 1778 right in the middle. That is just, it looks like a pimple or a zit, but it'll show up anywhere, like on a leg hair or something. It's just an infection of the hair follicle, and oftentimes it's no big deal. So you can just sort of pop it, rub it with some warm soapy water, and usually goes away if it's not a huge issue. That's about it for the infection ones. Some of these infection ones, you do need to find out, because remember a couple weeks ago, I think it was in the immunology lecture, we were talking about MRSA can show up, and that'll show up as a sebaceous cyst, like a blistery kind of cyst. And when you go in, send your patient in, and they get that biopsied, it'll come back as methylene resistant. And you do need to be a little bit cautious with that one. And then usually they have to go on an antibiotic that's not one of the Cillins. I don't think your chapter mentions MRSA, but you need to keep that in the back of your head. Oh no, it does. It does. Yeah, it does say MRSA. It talks about MRSA on in the middle of page 1779. Sorry, I guess I'm in my throat. Okay. Yeah, so it does. The MRSA thing right under medical management, because you do need to figure out if that little pimple or boil is MRSA, because you don't want to be popping something and having MRSA fly everywhere. Okay, then the next thing that I want to talk about are the viral infections. You can have, besides the ones I just talked about being bacterial infections, you can have a virus that can affect the skin, most notably herpes, the herpes virus. You've all heard about this. The herpes virus is also called shingles. So if you've had chicken pox, if you've had the chicken pox, the virus can sit inside the body, and then as the person ages, as their immune system, they think it's that when their immune system starts becoming weakened, or if they are in the presence of a weakened immune system, like our HIV patients or something, then that herpes virus that has been laying dormant for years can get reactivated and can go through the nerves that it's been sitting on those nerves, and it can cause excruciating pain. I'm guessing you've seen the advertisements because there are some pretty good medications out now to treat shingles. Shingles will show up with a rash and with associated discomfort. Very, very uncomfortable because it surrounds the nerves, and oftentimes they get rashes. You do get a little bit concerned if that rash is up near the face. Most of the shingles will start like up in the head and neck just because it sits on those nerves, which are the cranial and spinal nerves. But you do have to be a little bit worried because if that rash starts getting too swollen and inflamed without proper treatments, it can cause airway obstruction. So you need to be a little bit cautious of that. And the treatment with somebody who does end up developing shingles, recognize it right away and get them to see a healthcare provider to get them on some of these antivirals that are out right now, and they're good. I'm sure you've seen their commercials out. They're good, and they really help reduce the course of shingles, which can last up to a couple months, and they can help reduce the pain that's associated with it because it's a pretty painful disease. Herpes can be on the skin. And you'll see like the cold sores showing up. Herpes, there's a type 1 and type 2. Type 1 is usually on the skin. People that are prone to cold sores, they tend to get herpes simplex up in their mouth. But type 2 tends to show up in the genital region, and that's herpes. It's one of the STDs that we'll talk about when we're talking about reproductive, but it's one of the sexually transmitted diseases. You can transmit herpes zoster that way. So kind of focus on or not just skim through herpes and shingles as one of the viral, that's the major viral skin infection. There are some fungal skin infections, not a ton, there's not a ton. Like ringworm is probably the most common, and that's really itchy. Try to think of some other ones. The section in your book is not huge on that. Athlete's foot, yeah, I'm sure you've heard about that one. Athlete's foot is pretty common. Okay, so then the parasitic skin infections, meaning a little parasite, and the one that I know you've heard of is lice. Lice is just the little tiny itty bitty bugs. You do need to know about this as a nurse, especially if you end up working in the community, if you work in a school somewhere. You're going to have to be trained to look for lice. Lice is just a tiny little bug. Google a picture of it, or maybe if I remember, I'll put it on one of the PowerPoints. But lice can occur in the hair. That's head lice. It occurs in the hair, and it's often seen in the back of the neck or up around the ears like this. It will be about this far down on the shaft of hair. So like if you're looking through the hair, and it'll be on one little shaft of hair. I'll take out a bunch so you can see it. But the lice would be right about here. But it's tiny. It looks like a little tiny grain of sand. And you almost, if somebody is itching their head a lot, especially back here, if they've been at camp, if they share helmets, if they sit near each other in close proximity, like in schools or something, because an adult louse can jump. They're really good jumpers, and so if kids are putting their heads together, that's how it can spread. If somebody shows up with head lice, you have to go through every single little itty bitty, every hair, because that's how tiny they are. It's helpful if you're using a magnifying glass, and then you have to cut them out or pull them out or something like that to get rid of it. Because those are the eggs. They will grow into an adult louse, and then they just multiply. There are some over-the-counter medications for it. There's it's called NIT, N-I-T. It's a shampoo that you can put in, but the shampoo only kills the adult lice. That's why you have to go through and get all the eggs out, because the eggs will rehatch and then you have more lice. You can also have body lice and pubic lice, and there's different manifestations. Your book talks about that, but it's essential to get rid of because it can infect whole communities and schools and things like that. So that's lice. Keep that in mind, because I know you'll see that as a nurse, and if not as a nurse, for sure as a parent when your kids go to school. Scabies is not super common. That's much more common in developing countries, people that are malnourished and things like that. Now I'm on page 1783 now. The non-infectious inflammatory dermatological issues, those are the ones where the skin comes in contact with something it doesn't like and has an allergic reaction. A lot of chemicals will cause this. People that work in chemical plants, if you're doing like a lot of house cleaners who are around a bunch of hard chemicals, they can start getting itching, swelling, irritated skin, and it's because of something that they're coming in contact with. So you as a nurse find out what is it they're coming in contact with and how can we prevent this from causing a problem. If it's their livelihood, now we might have to do something where they have to use those chemicals or be near those chemicals. They may need to wear rubber gloves or some other kind of protection, wash their hands immediately when after they've been near that thing. You will find this too when you're working in the healthcare industry, because you put gloves on, take gloves off, wash your hands. You're going to be very, very hard on your skin, which you want to prevent the bacteria that's on there from contaminating things. But at the same time, if you're not also putting lotion on dry skin and stuff, it could crack and then you're reintroducing bacteria. All right, so the contact dermatitis is like eczema, basically. That's pretty, that's a fairly common dermatological issue that you're going to see. I do want to focus your attention on psoriasis. This is down on page 1784. Psoriasis is fairly common. There are a lot of people that have psoriasis, which is why I want you to know a little bit about it. And it's just, you can see a picture of it on figure 61-4, where it's just like thickened skin, a scaly skin, silvery kind of skin. It can show up at any age. Typically in young adulthood is when it shows up. There are some really great treatments for it, topical ointments and stuff, but it is sort of a cyclical disease. They do think there might be a little bit of a, like an autoimmune property to it. But it tends to, in patients that have this disease, when their stress level goes up, when they are fatigued, when they're dehydrated, then the symptoms seem to flare up. So that as a nurse, you wanted to try to get them, teach them ways to reduce stress, reduce anxiety, get good hydration, get good sleep, in order to prevent it, because it's embarrassing, especially if it shows up on the face. There's that commercial out now advertising a drug for it, like where that woman, she has to have her hair hiding over her face because the psoriasis is up here and she doesn't want it shown. So there are some emotional components too, so evaluate your patient for that. How you doing? How you feeling? Are you able to manage this? Do you need to see somebody? Are you depressed? Because it's a lifelong chronic thing, and people who deal with chronic issues tend to fatigue over those issues. Okay. Let's see, what else do I want to tell you about derm stuff? Blistering diseases that we already talked about. The ones I wanted you to know about, we already talked about. I'm on page 1788 now. Oh, yes, I did want to point this out to you guys on page 1790. This is the last of the non-malignant disorders that, it's probably the only non-malignant disorder that actually can be life-threatening as a derm issue. And it's the toxic epidermal necrolysis and Stevens-Johnson syndrome. It's on the bottom of page 1790. I want you to look through that because those can end up being fatal. Most of them aren't. We've got a lot of medications, a lot of ways to treat it now, but you need to know that these can, because they come on very quickly. And usually what will happen is it'll show up in the eyes with severe itching, and then there is usually a rapid onset of erythema, and it needs to be treated rapidly. Here's a rule of thumb in nursing. If it comes on rapidly and quickly, it's usually more dangerous because the body does not have time to compensate, or it's very aggressive, one of the two. So it needs to be treated and addressed, as opposed to something that's a little more insidious. You have a little more time to figure out what's going on and treatment options. Or in the body, if it comes on more slowly, the body has time to react to it, especially in relationship to fluid electrolyte status. That's just a general rule of thumb. All right, so look through TEN and SJS syndrome. Okay, now I want to talk about the skin tumors, skin cancer. And now I'm on page 1793. So some of the skin tumors are no big deal. You can have like cystic tumors, which is like a little fluid-filled sac, fatty tumors, little, sometimes like a sebaceous cyst can show up near nerve endings or in joints and make them a little bit sore, and they might need to be drained, like put a needle into it and pull them out, but they're not necessarily life-threatening. Warts are super common. I'm on page 1794 right now. And interesting, though most people don't know this about warts, is caused by the human papillomavirus. That's why people, like if you're in a public place showering, you should wear sandals, because the virus, if it's on the surface and you have any cracks or anything in your feet, you should tell this to your patients, the virus can get in there and then cause some of the warts. Warts, there's a lot of ways to treat them. There's a lot of products on the market now. Many of them are over the counter, so you can tell your patients to try some over the counter remedies. If the over-the-counter remedies don't work and the wart is continuing to grow, then they can go see their physician, where things like liquid therapy, liquid nitrogen, like the, yeah, it's liquid nitrogen. It's super, super, super cold, and they take it out with a really long Q-tip and just put it on there. It kind of burns it, just freezes it all the way down, and then it kind of comes out. Another old wives' tale, and some people swear by it, is a potato. You cut a potato in half, and this is, you'll never be asked about this because this is a wives' tale. So it's not going to be on NCLEX. I'm just telling you, if your patients have tried everything else, have them cut a potato in half, rub the potato on the wart over a series of several days, might take up to a couple weeks, and there's something in the enzymes in that potato that will make that wart go away. That's just free information. Nobody's going to ask you about that, nor will you be tested on it. But you'll sound like a really smart nurse if they've tried everything else, every medical thing that has been tried. Okie doke. An angioma is it's a little vascular tumor where the arteries and the veins come together. Actually, my daughter has it. Bailey, what? Can you come here? My daughter Bailey was born with arteriovenous tumor right here on her hand. She's been evaluated for it, but it's really, really hard to fix it surgically because of the vascularization. They're afraid. Come here, I want to show them your AVM.
Oh, I do not look cute enough for this.
Just your hand. I just need your hand.
Well, you
come here. Okay. I just need your hand. See right here? This is my daughter's hand right here.
Do they want to
That is, yeah, put it up there close.
There's my hand.
That is an angioma. Hold it real still so they get, yeah. That's, okay, thank you. You're excused. Okay. Thanks, honey.
Bye, friends.
That's an angioma, and that's where the arteries and the veins come to, like in a little tumor. That can be painful, so when she's like doing gymnastics and she's on her hand, it can be very painful. The problem is, treatment can be also difficult because you can infarct an area. So that becomes a little tricky. So now she's just having to live with that, and we've chosen to not have surgery because she doesn't want to run the risk of losing fingers. Keloids, I do want to point out keloids. A keloid is basically an overgrowth of a scar. So you know when you get cut, or your patient gets cut, or your patient has surgery, there's scarring there. You want the scarring to occur because that makes the part that was injured, it makes it really nice and tight. It lays down fibrinous tissue, makes it really tight. In some patients, kind of like patients who have allergies and hypersensitivities, the same thing happens in some patients with scars, and the scarring process where this laying down of fibroids occurs, it just gets out of control. And so pretty soon over the scar, it just becomes this big wad, almost looks like cauliflower, your book doesn't have any good pictures of it, but I've got some good pictures, so remind me. I'll also put these on some PowerPoint pictures so that you can see what some keloids look like. The problem with keloids is then they can go in and they can remove the keloids surgically, but because the person is predisposed to hypergrowing scars, it perpetuates the problem. So you go and have surgery, you get another scar, and then you get the overgrowth again. So it's a little bit tricky, but it's not malignant. All right, now I want to point out the skin tumors. Skin tumors, like the skin malignancies, the basal cell and squamous cell carcinomas, they're very common in the United States. The role of the nurse is to prevent them. This is why we tell everybody when they go outside to use a sunblock. More common in light-skinned people, people that tend to burn outside, red-haired people with fair skin, blue eyes are at higher risk, just because they have like almost zero melatonin in their skin, whereas dark-skinned people have a lot of it. It tends to be a little bit of a protectant agent, although everybody needs to be using skin protection. So down on page, on figure 61.5 on page 1795, the first guy there on his nose has a basal cell carcinoma, and by basal cell I mean that's just the cell where it's originating from. That's how they can tell. They send it to pathology and they can tell that that's coming from the basal cells. Compared to the guy in B, it's a squamous cell. So that's just something that you'll find out, or that the pathologist will tell you. Once they'll get a biopsy of it, they'll send it to the pathologist and he'll tell you which cell it's originating from. That's how you know. Now, when you're doing your skin assessment, that's why it's so important to assess everywhere in the skin, even those hidden areas like in the scalp and everything, in case they have a hidden skin cancer. Skin cancer is easily treated if they can get it early. However, if skin cancer metastasizes, and it can metastasize 15, 20 years later, if it metastasizes, when it comes back years later, it will often come back with a vengeance and be deadly. So at first, it's easy to treat. They take it out. They're followed by their dermatologist. Everything is great. And oftentimes that's the end of it. Oftentimes they don't need chemotherapy or radiation. They can just, take the tumor out, and then they follow it. But sometimes if there's just one little baby cell left, that they didn't recognize and it comes back years later, it can often be deadly. So that's the problem with skin cancers. Okay. Yeah, the melanomas, you see, this is the other thing I want to point out. Look on page 1795 and see the guy who has A and B. So let's say you're doing an assessment on a person, and you find these kind of lesions. How do you know that that's not just a scab or something else? It looks kind of irritated. That needs to get evaluated. Send it to the dermatologist. But now look at page 1797. Look down there at the bottom. A classic sign of a melanoma is a skin lesion that is discolored, irregularly shaped, growing or moving. Those are never good signs. Bluish in color is not good. So anytime you're looking at a lesion in a patient like that where it just looks not pretty, you need to assess that and follow it and have that person go to a dermatologist, because it could be that the dermatologist will biopsy and find out that in fact it's just a mole or a hyperpigmentation that the patient was born with. But you don't want to overlook a melanoma, because if you get the melanoma out early, great. If not, and it metastasizes, then it can be a little bit more deadly. That's the problem with the melanomas. Okay. Is that all I need to tell you guys about? Grafts. Kaposi sarcoma. We'll talk about that. Oh, we did talk about that with in our allergy HIV lecture, because that's the one that shows up in patients that have end-stage HIV. The Kaposi's sarcoma will start showing up. So that's the same that we talked about during the HIV week. And then the flaps and the grafts, we're going to talk about that in right in the next lecture when I start telling you about burns, like in fixing burns with different kinds of grafts. And then the cosmetic stuff, you don't need to know about that. That's just, the facelifts, the Botox and stuff. You don't need to know about that. Okay, so that's it for here. And then I'll do one more on chapter 62. We'll talk about burns. Okay.